Hi. So good. I guess good evening for everybody in Europe. It's morning in Toronto. I'm Jay Wunder from Toronto. I'm one of the orthopedic oncologists at the Toronto Sarcoma program. And Bruno asked if I could do a seminar for everybody talking about margins and soft tissue sarcoma. And I thought that we could bring together the sort of Toronto experience or the Toronto perspective on dealing with soft tissue sarcomas in terms of margins. So I'm going to talk a bit about orthopedic oncology perspectives. Carol Swallow, who's a general surgical oncologist, is going to talk about retroperitoneal sarcomas, some of the work from the transatlantic group. Brendan Dixon's our pathologist, going to talk about challenges with margin assessment, especially with multidisciplinary care and pre-op treatment pathology. And Charles Catton's our radiation oncologist, who's going to talk about how we sort of work together as a multidisciplinary team. And I think one of the reasons that you'll see that we've been able to be so successful in providing really good outcomes for patients, not just cancer outcomes and functional outcomes, is by having a really good multidisciplinary group. And we see all our patients together in a common clinic, and we talk about all our patients at tumor board. We operate together, and we have a very good working group and working relationship in how we approach most of our cases. You'll probably notice, at least, we're not going to talk really much about chemotherapy at all. I've sort of left that completely off. Probably many of you know we don't typically use chemotherapy a lot for upfront neoadjuvant treatment for soft tissue sarcomas, and we can certainly answer questions that people have about that, but I've tried to leave that out of our talk today. So I'm going to talk a little bit just about sort of the extremity and orthopedic oncology issues as a start. And clearly local control is one of the prime objectives, at least for the surgeons, because that's really within our purview, and that's what we're largely responsible for. And achieving local control is most closely related to the quality of the surgical margin. Now, there's a lot of other factors that affect local control and affect patients' risk of local recurrence, but the margin is the most important by far, and that is to a large extent under our control. And so there's a cost to having high local control in terms of sacrificing tissues to have adequate margins, and that affects functional outcome. So compromises in treatment are sometimes required depending on whether you're trying to emphasize local control or you're trying to emphasize functional outcome or trying to find the sweet spot for those. So surgical decision making is largely a balance of local recurrence risk and functional impact for the patient. And one of the big problems in the extremity is that most of the tumors are large and they're close to what we call critical structures or fixed critical structures, like a major blood vessel, nerves, or bone. And resecting those negatively affects function. And so it becomes very important to understand what's a safe margin, when can you save those structures, is it worth saving those structures, and that's a balance. So to start out, there are a group of patients who don't require multidisciplinary management and can just be treated with surgery alone in the extremity. And these are patients where we can perform a wide resection. So these are usually small superficial tumors, like you see at the top or the bottom here, sometimes small deep tumors where it's easy to achieve a wide resection with an adequate muscle margin. And they're tumors particularly that don't have much surrounding edema, and we'll just mention that issue a little bit briefly in a sec. So we typically aim for about 1 or 2 centimeter margins, for sure at least a 2 centimeter margin, if not more, or a fascial plane around superficial high-grade tumors. And we expect to achieve over 90% local control. And we try to discuss these cases at tumor board, even if they're only having surgical management. And so when we looked at our wide resections alone, there was about a 6.5% local recurrence risk. That's pretty consistent with large series from MD Anderson at 11% and Dana-Farber from 7%. And the question, though, is even doing a wide excision, there's still this 5 to 10% local recurrence risk. And why does that happen? And that relates to this biology diagram where there's a tumor and then there's the zone around the tumor that's often referred to as the inflammatory zone or the reactive zone. It's a zone where we know there's often microscopic disease. So if you don't resect beyond the area of microscopic disease, there's going to be a significant risk of recurrence. If you resect, basically one cell past that last tumor cell, then it shouldn't recur. But the question is, where is that? And that's a biologic determinant. And there's some quantitative assessment that goes into that. So one of the issues is this issue of peritumoral edema, and we've sort of shown that peritumoral edema can often be used as a surrogate for looking at the extent of this microscopic zone of how far tumor can extend. We did a study where we looked at the histologic assessment of the margin around tumors that were resected without preoperative radiation or chemotherapy to try to assess whether there was tumor in these very extensive areas of perilesional edema that we commonly see in a lot of soft tissue sarcomas. This is a tail that's associated commonly with UPS and myxofibrosarcoma, but a lot of high-grade sarcomas have this extensive perilesional edema that extends very, very far away from the tumor, much further than you could realistically ever resect. And in these cases, we found that in 10 to 15 cases, we actually could identify cells beyond the edge of the tumor. In 6 cases, the cells were within 1 centimeter of the margin of the tumor, but in 4 cases, they were out over 1 centimeter away, and in some cases, even 4 centimeters away from the tumor. So that particular case, you can imagine if you only took a 2 centimeter margin as your wide margin, and the tumor cell is actually 4 centimeters away, you potentially be leaving tumor cells behind that could recur. That's part of the explanation of why tumors recur despite what we think is an adequate resection. The other thing we found is that a lot of the satellite tumor cells were in areas of peritumoral edema. So we always take peritumoral edema into account in terms of whether we can do a wide margin. And we always take that into account in terms of providing multidisciplinary care and what the radiation field has to cover. And Charles will probably talk about that a bit too. So, the big issue though is most sarcomas require multidisciplinary management. Like here, this huge thigh sarcoma. You can imagine this tumor is probably near the nerve and the blood vessel and the bone. And even without that, it's involving the whole medial thigh, and it's going to be really hard to have a negative margin soft tissue covering this. So we really rely on combined management for these tumors. Now, the big issue though is that, as you can see in this posterior thigh sarcoma, here's the vessels separated by a fat plane, but here's the sciatic nerve right on the tumor. And the question is it safe to save those nerves? Obviously, saving them is functionally important, but is that going to leave a positive margin? And is that going to be negative in terms of local recurrence and potentially even systemic recurrence risk? So salvaging major nerves, vessels, and bone is a big issue in extremity sarcoma. When we try to do that, it's almost always combined with neoadjuvant therapy, but the question really remains, are these margins actually safe? So if we're going to talk about margins, we have to have a common definition. I'm sure that Brendan in the pathology is going to talk about that more, but how close is too close and how do we define margins? So we're talking about the same thing consistently within our group and between groups. We use the R0 margin classification. And so if we paint the tumors with silver nitrate, if there's tumor cells right at the ink, then we call that microscopically positive. So one of the problems then is when we approach this case and we want to resect the tumor, we might have a thin margin of normal tissue surrounding it, but in the areas where we want to salvage these nerves and we dissect through the epineurium, we don't know if the margin is going to be negative or positive until we're at tumor board a couple weeks later. But it's really important to know whether that, if it turns out to be positive, is that going to be safe? So here's an example of the same tumor that's being basically resected except for the sciatic nerve running through the tumor. We've separated the tumor with a green towel, and now we're trying to see if we can salvage the nerve and dissect it along through the epineurium away from the tumor. So here we are as a close-up. There's the nerve. It looks like it's entering and exiting the tumor, but we know it's just on the outside of the tumor covered by this thin layer of tissue. We open the tissue, we open here we are opening the epineurium. Here we've dissected along the fibers of the nerve, and this is our true tumor bed now. And so this is really the area where when we take this out to the pathologist, we paint it. We usually paint the tumor bed where we just dissected the nerve with a color. So it's really clear and evident. So when we come to tumor boards, we can determine whether this tumor bed resection along the nerve is microscopically positive or negative. And here's the saved nerve in this case. So here's another similar problem. This is a myxofibrosarcoma. It's in the quadriceps. It's right on the femoral vessels and femoral nerve. And here it is sitting right on the femur. Clearly taking out the femoral nerve and vessel and the bone would be really morbid for the patient. And so what we really want to do is try and save those structures. But again, is our margin going to be positive or negative? And if it's positive, is that going to be safe? So what does that look like? Here we've opened our skin flaps, and here's the tumor. There's the previous biopsy site. It's covered by fascia. Here's the femoral vessel. Here's the femoral nerve right adjacent to the tumor. So here's just the close-up. So we've mobilized the nerve. Now we're dividing the side branches so we can mobilize the femoral vessels. Here the vessels and the nerve are moved away from the very edge of the tumor mass. And here we are lifting periosteum off of the femur, and then that's going to provide a periosteal layer. But again, whether this layer where we've just dissected the vessel through the adventitia or we've dissected the periosteum off the bone is negative or positive microscopically, we won't know until we show up the tumor board. So what are the results of this? Well, Patrick O'Donnell, who's our fellow who now works in Kentucky, sort of did a paper looking at not only these planned close but ultimately positive margins along a critical structure like nerve, vessel, or bone, but he tried to categorize the positive microscopic margins after resecting soft tissue sarcomas so that it made sense. And you'll see that we're not really talking about distance here. I know that when Charles does his talk, he's going to talk a little bit more about quantitatively defining margins, but here we're really talking about qualitative scenarios. So here's a group of 1,200 of our patients who had negative margins, and the local recurrence risk was 6.5%, pretty low. Here's the group where we had these planned margins that were going to be very close. We saved the nerve, vessel, or bone, and the margins ended up being positive, but the recurrence rate was only 9.5%, not too far off from the negative group. Then he defined a group where people that had a prior WOLPS operation or inadequate or incomplete excision elsewhere, they were referred to us. We redid their surgery or tried to achieve a negative margin, but in some cases we ended up with a positive margin once again, and those patients had a very high 25% local recurrence risk. And then finally, there's a group that he called inadvertent positive margins. These are usually large, deep sarcomas that present primarily to us. We operate on them ourselves, and we end up with inadvertently we end up with a microscopic positive margins, not along a nerve, vessel, or bone, but generally through the soft tissue envelope that we're trying to cover the tumor with. And in our hands, if we end up with an inadvertent soft tissue positive margin, that's even worse. That's a 33% local recurrence risk. So this sort of defines these quantitative groups. Now, this just shows the same thing in a Kaplan-Meier format. So here's the negative control group with 90% local control at 10 years. Here's the group where we ended up with a positive margin to save a nerve, vessel, or bone. No statistically significant difference between these groups, which is reassuring. But again, we see that patients who have a positive margins after we've tried to salvage a previous WOLPS procedure have a 30% recurrence risk locally, and the inadvertent positive margins have a 40% local recurrence risk. So you can see this increased gradation of local recurrence risk. So, you know, we really wanted to look closer at, again, this group, these positive margins along critical structures. Is it really safe? And, you know, if we end up with a positive margin, are we doing a disservice to the patient? Is it really worse for them, or is it worse for their metastatic risk? So we need a really good comparison group, and probably it's not all people who have a negative margin. It's probably patients who had large tumors adjacent to the same critical structures that we resected, but ended up with a microscopic negative margin, as opposed to the microscopic positive margin. And so here's a case here of a large posterior thigh buttock sarcoma. It's right on the femur. It's right on the sciatic nerve. We did a marginal excision to save the bone and the nerve, and we ended up with a microscopic positive margin. So we wanted to compare that to patients who had similar resections with negative margins. And we also took a third group, tumors where a vessel or a nerve were encased in the tumor. So we resected the tumor with negative margins. We resected the nerve and vessel. How would they do? We matched all these groups for size, depth, and grade, so they were all very, very well matched. And this way, any differences in outcome we could attribute either to just the microscopic residual positive margin or to tumor biology. So the second comparison group was, here's a posterior popliteal fossa tumor. It's right on the perineal nerve. It's right on the popliteal vessels. We resected this. The margins turned out to be microscopic negative. And here's the other comparative group, is a posterior thigh tumor. The femoral vessels are directly encased in tumor. We resected the entire vessels and reconstructed them. We resected the tumor with a negative margin. So here's what we found. First, look at local recurrence. So here's our group of patients, the same curve as before, where we salvaged a nerve, vessel, or bone and had a microscopic positive margin. Here's the group where it was a similar operation, but the margin turned out to be microscopically negative, significantly better, about 10% difference. But look at this group. This is the group where the vessel or nerve was encased. We resected the tumor, resected the nerve and vessel. The margins were actually negative, but the same local recurrence risk, around 85%. Okay, and again, these groups were all equally matched for grade, depth, and size. So now let's look at metastatic risk. So the patients who had a positive microscopic margin along a nerve, vessel, or bone, have a 50% metastatic risk. Well, largely that's because those are large, deep, and high-grade tumors, so it's not surprising. But when we look at this comparative group where we had a negative margin by resecting the encased nerve and vessel, they had the same high metastatic group of 50%, even though the margin was negative. So it sort of suggests that the poor outcome here in terms of metastasis is not necessarily just related to having a microscopic positive margin, because this group was negative. It's something about the biology. And here's the other group, the patients where we did marginal resection but ended up with a negative margin on the nerve vessel or bone. They did significantly better, possibly because the biology is better. So this leads to another question, at least in the extremity, is what's the best margin classification system to use? We're all familiar with the R0 classification. We know the R+1 classification. And Kenny Gundel from our group described this, it's called the Toronto Margin Context Classification. And it really just uses that same chart that I showed you where it looks at negative margins. There's a slightly but not statistically different risk of local recurrence with microscopic positive margins along a nerve vessel or bone. A higher risk if you get a positive margin after trying to salvage a WOLPS procedure in terms of local recurrence, and a much higher local recurrence risk if you have an inadvertent soft tissue positive margin. So this, again, is not looking at quantitative margins, it's really looking at margins much more qualitatively, but you can see that it really separates out risk very, very well. And so this is the Toronto Margin Context Classification that Kenny Gundel wrote up. So then in the extremity, then if you think about margins, so local recurrence is obviously closely related to positive margins, but it depends also on the clinical context, and not all positive margins, as I've shown you, are equal risk to the patient. It's important that we consider this group where we resected the critical structures, we resected like major nerves or vessels to get a negative margin, and it did not improve their oncologic outcome in terms of local recurrence risk or metastatic risk. So it's the biology that's important. So this suggests that biologic aggressiveness of these tumors and their ability to invade critical structures is what leads to them having a worse prognosis. And it sort of suggests this idea that bad tumors just do badly, and sometimes they can do badly despite good surgery. Panachek, he's a radiologist at Sloan Kettering when I was there doing my fellowship and when Carol was there. And he did a paper showing that tumors that invade bone had a worse survival. My partner, Peter Ferguson in Toronto, we published a paper in Cancer showing the same thing, that patients with bone soft tissue sarcomas that actually invade into bone histologically have a worse survival. And this study also documents that tumors that can invade nerves and vessels similarly have worse local and systemic outcomes. Again, getting to this idea that tumors, some tumors just do really badly. And it also supports this idea that saving nerves, vessels, and bone and accepting microscopic positive margins in that context is relatively safe and does benefit patients' functional outcomes. So thanks very much. This is our Combined Cancer Center at Mount Sinai and Princess Margaret in Toronto. And that's everything related to margins for extremity sarcoma. So thank you very much. Great. So next I'll just introduce Carol Swallow, who probably many of you know. So she's one of our general surgical oncologists. She's actually the professor of general surgery at University of Toronto, and she's done a lot of work in the transatlantic retroperitoneal sarcoma group, and she's going to give us the RPS perspective.
So thanks very much, Jay, and also I'd like to thank Professor Fuchs for the invitation. And what I've done is organize my talk to begin by distinguishing retroperitoneal sarcoma from extremity. And I think it's a nice segue from Jay's talk. In retroperitoneal sarcoma, we actually have an R2 issue, not an R2 issue as opposed to extremity. And then I'll talk about what an R1 margin means. And then I'll talk a little bit about extensive resection in retroperitoneal sarcoma. There we go. First of all, to compare outcomes in retroperitoneal sarcoma to extremity. I think most of you who operate in the retroperitoneum know that there is a marked difference, and retroperitoneal sarcoma has the worst prognosis of all sites of soft tissue sarcoma. This is our own data from Toronto from some time ago. And then this is the Trent cancer region. This is a more population-based example. And you can see, again, retroperitoneal sort of the worst outcomes possible. The other thing that's important to know is that the risk of a recurrence, and we consider any intra-abdominal recurrence that is not in the liver to be local recurrence. So abdominal recurrence is local recurrence for retroperitoneal. The risk of recurrence continues out to 15, 20 years, 25 years. Patients are still recurring regardless of what group around the world you're looking at. So is this under our control? Jay talked about, the margin being under surgical control versus is it a reflection of biology or is it a reflection of location? And we just can't do too much about that. So there are inherent technical challenges with anatomy that we cannot sacrifice and keep the patient alive. There are also issues with exposure and safety. And then there are the patients who are compromised by the size of their tumor and have become malnourished, deconditioned because they can't move, they can't breathe due to the bulk of the tumor, and may not be suitable for resection. A very stark contrast is the local recurrence rate, and Jay showed the excellent local recurrence-free survival in the Toronto experience. Overall, it's about 84%. In extremity sarcoma, for retroperitoneal, overall, it's less than 50% local recurrence-free survival at 5 years. So a very stark difference. And that's demonstrated clearly in this collection of data from Memorial Sloan Kettering from a couple decades ago, just showing the increased risk in retroperitoneum versus all other sites for getting a positive microscopic margin. So are these two things related? So it's also very clear that not all retroperitoneal sarcomas are the same as each other. This seems kind of obvious at this point, but a couple of decades ago, we didn't recognize this so much. Leiomyosarcoma, liposarcoma, solitary fibrous tumor, MP and ST, these are the top histologies. They all have very different patterns of recurrence, and as you'll see, margin positivity rates. And this was not nicely shown in this large collection of patients from our transatlantic Australasian retroperitoneal sarcoma working group, TARP-SWIG, where we demonstrated that well-differentiated liposarcoma, although the distant metastasis rate is almost zero, as you expect, the local recurrence rate is quite high, even by 5 years, and continues to increase. And that's in contrast to leiomyosarcoma, which is high distant failure, but low local failure rates. I'm going to start by talking about R2 because there's still an R2 problem in retroperitoneal sarcoma. And we obviously, as a community, have stated that R2 is to be avoided. It's not so difficult as you might imagine for this to happen. If you don't notice this small bit of liposarcoma here, and you get distracted by taking this out, you may leave this behind at the time of the surgery, and this grows and inevitably is going to cause problems for the patient. So that's an R2 resection. In general, R2 has similar outcomes to no resection in a couple of large series. And, this could be related to biology, but also the growing of that R2 unresected disease. How to avoid it? First of all, you need to recognize the extent of a retroperitoneal liposarcoma, and it can be sneaky. And here you can see there's some liposarcoma outside of this main mass. This can sometimes be misinterpreted as multifocal disease. It's one big liposarcoma. In expert hands, R2 resection can be avoided through appropriate planning, which involves our colleagues in imaging. And you can see outside of our center in Ontario, in this review that we did, the R2 resection rate was actually about 25%. In expert centers, the R2 resection rate has been going down over time, as you can see from this group of 10 centers that we put together. We're down to less than 3% R2 resection, so gross residual disease. Resectability is an issue unto itself and is very relevant in the retroperitoneum. There's some tumors that, for safety, are unresectable. And who decides this? Well, one thing we've mostly agreed on is if patients have distant metastases, they're unlikely to benefit from resection of their primary if they have poor performance status. And then there's this technical unresectability. What does that mean in the retroperitoneum? And these variables go together to making a decision about whether this patient should undergo resection. And we also sometimes use other treatments to make a decision, and time also helps us about who should have an attempt at resection. So a couple of examples. This patient, you can see very large dedifferentiated liposarcoma that extends to surround the common iliac vessels, the arteries here, extends over the IVC quite extensively, extends to the contralateral ureter, and we called this upfront unresectable in our group. This tumor was called borderline resectable by contrast. And I'll tell you that these two patients, both of them had what was called neoadjuvant treatment in an attempt to make them a difficult resection rather than unresectable or borderline resectable. And it was the one who was called unresectable who, after chemo and radiation, eventually, and some time, we took to the OR and resected. And the one that was borderline, he developed peritoneal metastases and ascites and died very quickly. So in a sense, this pre-treatment is a test of biology and fitness of the patient. I can also say that we use the most effective cytoreduction that we get out of chemotherapy is in patients with leiomyosarcoma. And this is an example of someone who had a giant leiomyosarcoma presentation, and after adriamycin ifosfamide, 5 cycles, ended up with a resectable tumor that we did remove. So coming on to R1 margins and what that means, Brendan may talk about the elusiveness of microscopic margin assessment in retroperitoneal sarcoma, and what does it reflect? Is it a surgical failure or is it tumor biology? And Jay showed you this data on extremity sarcoma and the big difference in local recurrence rate if you have unexpected positive margins. Is this also true for retroperitoneal sarcoma? And this slide I showed previously, it looks like in these large series, R1 and R0 are not really that different in retroperitoneal sarcoma. But this isn't true for all series. This is an example when Sam Singer was still at Harvard and working at Brigham and Women's. Here you can see an R0 margin and an R1 margin. There was a difference. This is a small series. When Gary Mann was at University of Washington, they put together this paper showing a high R1 resection status, and the R1s actually paralleled the R2s in their series. This is data from Seoul showing R0, R1 statistically significantly different in terms of disease-specific survival and a fairly modest R1 rate. And this is from our own series. This is from a couple of years ago. showing you our R1 rate. And interestingly, it seemed like those patients had worse local recurrence-free survival and overall survival. But there's obviously confounding by histologic type. And the R1 rate in leiomyosarcoma, which has a high distant failure rate and a low local recurrence rate, is lower than in other histologies. This is in our own series. We decided to examine this in an expanded group and collaborated with various other centers to just look at this exact issue. So you can see that R0, R1, I mean, any extremity sarcoma surgeon would be horrified by this, but this is reality in retroperitoneal sarcoma. So 50-50, probably generous. And you can also appreciate here that the R1 status varies according to the histology of the patient. And LMS had the lowest R1 rate, and we used it as the reference. And these liposarcomas all had higher R1 rates. What about local recurrence? So we did a multivariable assessment in this group of patients, and you can see that margin status, even accounting for histology, multifocality, and grade, margin status was independently prognostic for local recurrence. We went on to look at that well-diff liposarcoma and low-grade, so-called dedifferentiated liposarcoma subgroup in this multi-institutional series. And you can see that R1 remained statistically significantly worse in terms of local recurrence compared to R0. And this brings in a reflection to do with the STRAS trial results. I think you're all familiar with the fact that overall the trial was negative, didn't show any benefit to preoperative radiation for retroperitoneal sarcoma compared to resection alone, but there was a signal in liposarcoma, particularly well-diff and low-grade D-diff, that there might be a benefit in terms of abdominal recurrence-free survival. And you can see here when we pool STRAS and Strexit were patients from the same time period at the same centers who were not entered on the trial. There appears to be abdominal local recurrence-free survival benefit in those who had preoperative radiation. And when we looked at our multi-institutional study, we actually saw in those with an R1 resection, those who had pre-op radiation appeared to have a lower local recurrence rate than those who did not. So this is a more homogeneous group of patients showing a signal of benefit for preoperative radiation. And hopefully we'll get on to some discussion of that. I'm not going to go into too much about extent of resection, just to say that it is controversial. It has many names associated with an aggressive approach, and the French sarcoma group in particular has been a champion of more extended resection and shown that surgeons with greater experience in management of retroperitoneal sarcoma achieve better results. Now, I want to acknowledge that those surgeons don't work in isolation. They work with multidisciplinary groups. And I am sure that it's not just the surgery, it's a group of radiation oncologists, medical oncologists, imaging experts, and pathologists who contribute to a multidisciplinary decision that results in better outcomes for those patients. So I'm going to end there and look forward to your questions in the discussion time. Thank you.
So thanks, Carol. I think, it brings up a few very big differences that we face and challenges. In the extremity, we've been able to largely diminish the problem of R2 resections, but they still happen in the retroperitoneum. And whereas you have tumors that are unresectable, we can always do an amputation. We always do have that available to us, or we can always cut out the nerve or the vessel or the bone. We do have ways to do it and reconstruct them. We've shown that it works. It's more morbidity, it's more complications, it's worse function, but we have all those things available to us that you don't always have. And again, where you have tumors that are just, they're so big you can't get around. I mean, we do have times where an amputation is difficult for proximal joint tumors, but it's easier to do that in our setting than when you have an unresectable tumor, as we often acknowledge at tumor boards when, you know, you guys show us your extreme cases and you always win, right? Because they're so unmanageable. And so it's also interesting that, you know, our R1 margins that are along fixed structures do well, but our R1 margins that are unplanned, or as Kenny called them, inadvertent, just like your R1 margins, seem to be worse. And so you can't always control for those, largely by tumor anatomy or tumor size. You know, so a lot of those things just show up, and we have to manage them and accept those limitations. So that's great. I mean, so some of our stuff parallels very nicely, and clearly there's a lot of big differences though. So maybe Brendan, this is a great pairing to pathology, since, you know, everything that we've talked about so far is largely being related to what the final margin assessment is. And I don't know if you're going to talk at all about sort of intraoperative margin assessment, and sometimes we could talk about that after. You know, is it valuable or not valuable, trying to look at the margins while we're still operating and make decisions based on that. So we know there's a lot of, we know we give you a lot of challenges, and we're happy for you to articulate them all now for us, back to us.
All right, a lot more than I can fit in for 10, 15 minutes, Jay, I can assure you. All right, thank you. So I'm very grateful for the opportunity to speak today, and in particular, Dr. Wunder for the invitation to join this group. The goal, of course, today is just to highlight some of the challenges from a pathology perspective with this talk that have actually been nicely set up by Dr. Swallow at a couple of instances. And just to begin, I mean, from a pathology perspective, I realize that as a pathologist, this is a topic that's not terribly of great interest to many surgeons. And before the attendees start dropping off, I want to assure you that I'm going to not be getting into anything terribly in depth. But there's often a frustration that comes when people don't understand why. For example, I can't be definitive in a margin. A surgeon may say, well, you know, you've got a tumor, you've got ink, why can't you just measure the distance and be done with it? And in reality, the situation is much more complicated. There are multiple, both pre-analytical and analytical contributors to margin assessment. And this is both at the level of the gross and microscopic evaluation of margins. And there are other things that we have to weigh, including relative importance. So Carol mentioned leiomyosarcoma, for example, as a histologic type. You know, we worry about grade, distance from margins, an R1 versus an R0, and obviously there's different classification systems for assessing margins. Personally, I'm much more in favor of a continuous variable, and whether or not there are anatomic structures present like fascia that might be a mitigating factor. So there's lots of things that we have to take into consideration. And of course, with all of these variables, there are you know, a plethora of different options and permutations that are possible, which makes studying these things very, very challenging. And as a result, there's often very limited evidence, but no shortage of controversy, of course, when it comes to many of these things. So I'm going to just give you more in a case format, and with each case more or less an amuse-bouche, really, of an issue that comes up with pathology. And some of these, I hope, will form the nidus for broader discussion. So the first case is that of a 31-year-old who presented with a back mass with an outside incomplete excision of a leiomyosarcoma. And the mass is re-excised and was so here at our institution. And importantly, when looking at a gross description, you see right off the bat that there's a scar, and the pathology assistant here did not see any discrete lesion identified. And at some institutions, it might suffice to just take a section through that scar, document the scar, and then be done with it. In our department, what we do is we still continue to sample margins as if this is a sarcoma, and then we submit the scar in toto. And this next slide that I'm going to show you is a cross-section of that scar. And again, this is from the back, so we know that the dermis is very thick. And it's not surprising then that the pathology assistant didn't recognize the presence of extensive tumor. Moreover, not only is the dermis completely replaced in large part by tumor, the tumor tracks along right up to margins. And so here just a higher magnification showing tumor marching up to the inked margin, and indeed confirmed by immunohistochemistry. So what is the issue here? Well, obviously it's a positive margin that wasn't grossly apparent. And what does this reflect? Well, the gross assessment of margins and indeed tumor, as reflected with this case, can often be challenging and prone to sampling error, as you might expect. And there are a number of things that contribute to this. One of the big things, of course, is tumor type. So for example, many people working in the extremities will know that myxofibrous sarcoma is a frequent offender when it comes to this. These tumors track along fibrous septae, and they can be hard to appreciate on imaging and intraoperatively. And it isn't until we have the final margins in permanent sections that we can evaluate. And to Jay's point about, is there a role for intraoperative frozen assessment of these some of these tumors? Absolutely not. You know, to try to differentiate a myxofibrous sarcoma on frozen section would be near impossible, because they oftentimes just look like reactive fibroblasts. Next, we've got a DFSP that was diagnosed on a punch biopsy and now has come in for an excision. And you can see here within the dermis and invading into the subcutis with this prototypic honeycomb pattern of infiltration, we've got a DFSP. And when looking at the peripheral inked margin, you can see that the tumor has a healthy margin of less than 1 millimeter. So the issue here is a close margin. But is that really the issue? And the answer is no. With deeper sections through the tissue block, you can see, in fact, the tumor marches right up to the inked margin. And just highlighting the same thing at a higher magnification. So you can see the tumor right up at the cautery and right up at the ink. So we have here a microscopic margin following deeper sectioning. And what does this mean? And just a quick review for those of you that haven't spent much, if any, time in a gross lab. Here we've got a margin that's been taken out by a pathology assistant. You can see now that it's on end that it's been inked. It goes into a tissue block, goes into a tissue processor overnight. The next day it comes out. It's embedded in paraffin and mounted on tissue blocks. And then it gets mounted on a microtome, and it's cut into ribbons, cover slipped or put onto slides and stained. And so what does this mean to the case? Well, here we have that same chunk of tissue at a margin, the inked margin here, and we have the tumor inside, and it gets mounted on the microtome, and then the histotechnologist will basically cut sections. They'll square the block, and as you go through the tissue block, you'll see here with the asterisks and here elsewhere, as you go deeper and deeper into the block, multiple areas where you end up getting positive margins that you wouldn't have expected. So if you had just a superficial section, you might have called this negative, where in fact, when it's really, really close, it behooves the pathologist to cut deeper sections just to make sure that there isn't an area of positivity further down. So what is the point from this case, or the takeaway message? The pathologist only evaluates a 3 to 4 micron section of tissue, and we can only evaluate the tissue in that plane of section. So it's very, very possible that in a subset of close margins, coming back to a point that Dr. Swallow alluded to when it comes to retroperitoneal tumors and margin assessment, if you have a very close margin, you may falsely call something negative if you haven't sampled it carefully. And certainly, again, this is exacerbated with infiltrative tumors such as myxofibrous sarcoma. And just to make that point, here's a prototypic case of a myxofibrous sarcoma where you've got a lobulated tumor that's infiltrating skeletal, or actually, in this case, soft tissue, adipose tissue. And you can see that not only do we have this nice pushing margin in areas, which would probably be palpable to the surgeon, elsewhere it's quite infiltrative. And just to highlight that infiltrative area, we have pools of myxoid stroma with cells suspended within it, marching up dangerously close to this inked margin. And I suspect many of you have had the misfortune of coming back with an unexpected positive margin with this entity. So histology is often very, very important when it comes to margins and how we're able to get around them. So number 3, this is I've started this off as kind of a silly point, but to make a very important message at the end. So this is a patient that underwent a polypectomy, and you can appreciate that we have a polypoid tissue fragment. And what is the issue here? Well, you can see circumferentially around the tissue fragments, we have stratified squamous epithelium. And why is this an issue? Well, this is akin to an axial cross-section on your CT scan. I cannot assess a margin because we've got an axial section showing skin all around it. And what really needs to have happened is that the specimen should have been embedded on end, so that more like a coronal plane, I would be able to evaluate a margin. Obviously not a big issue with a small little ditzel like this. Obviously, orientation is the point that I'm trying to make with this case. But if I had a proper section, I could say that yes, the tumor marches right up to margin. Obviously, this is a silly little example, and the big point that I want to make is, what do I do now when presented with a specimen like this from a retroperitoneum, and how do I evaluate the margin if I haven't been presented with an orientation by a surgeon? And just to highlight and emphasize, if I can enough, the critical importance of having proper orientation with a specimen when the anatomy may not necessarily inform that for me or for a pathologist assistant. So the takeaway here being that the absence of a well-defined anatomic landmark makes it impossible for us to orient the specimen, not to mention the other effects that happen in time. So for example, we all have seen bowels contract before our eyes when they come out of the body. Fixation, if a tissue specimen sat in a bucket over a weekend, looks very different than when it went into that bucket on a Friday. But the real point here is that reliable and reproducible sampling rests at the feet of proper orientation. And what does this mean for retroperitoneal tumors, for example? I mean, I always get a little bit frustrated when a surgeon will say something rather blithely like a retroperitoneal margin doesn't matter. Well, I think Dr. Swallow has lovely illustrated with work from our group why that is not the case. And I think it's also a testament to people like Dr. Swallow. So, you know, after she has meticulously resected a 50-pound retroperitoneal sarcoma, she will hoist it over her shoulders like a sack of potatoes and bring it down to pathology. And she will take the time to sit down with the pathology assistants and carefully orient the specimen, much like Dr. Wunder alluded to with inking specimens once he's brought it out of the OR, just to highlight critical structures. And I can't tell you how important and how much that's respected and appreciated in the pathology lab, because that means that when we now go to sample those margins, we know exactly what it is we're taking, we know exactly what the issues are, and we can take more tissue if needed. We can sample additional areas if there's a potential gross concern of involvement. So again, margins matter, including the retroperitoneum, and it's really that concert of careful sampling combined with careful orientation that really makes the difference, much as we know happens in the extremities. And I suspect in time, this will be borne out with more and more rigorous studies that confirm, as Dr. Swallow showed, you know, the importance of margin status when it relates to retroperitoneal tumors in particular. This next case, I should mention, I guess I don't have a slide to show the clinical stem, but basically this is a patient that had a prior history of a sarcoma. That sarcoma on a needle core biopsy then prompted neoadjuvant radiotherapy and a resection. And what you can see here is now a tumor that's been resected. Obviously, we have very minimal viable tumor. We have a lot of fibrosis and reactive changes. So at one point, this was a viable tumor, and now it is not necessarily as apparent, but what is clear is that it marches right up to an inked margin. And even at this low magnification, you can appreciate some atypia. We assess pleomorphism and atypia at low power, and you can see here, we've got multiple areas where there's atypia sort of coming through the specimen, and what does this mean? And Jay talked about a paper at the beginning of his presentation that came out of our group, where there was atypia in tails, for example, and what does this mean? And I'm just going to show you very quickly, morphologically, what some of that atypia corresponds to. So here, for example, we have this multinucleated hyperchromatic cell. And I can tell you, you may be concerned about this, but I can look at this and say, well, this is clearly just a trophic reactive skeletal muscle. The tumor was once here, the native skeletal muscle responded by contracting into this somewhat of a syncytium, and we have no concerns here. Here I have a bit of hemosiderin. Again, the tumor was here before, and this looks like it was probably a reactive fibroblast to, again, that now void that's been created by the retreating necrotic tumor. But here we have something else, a very large atypical cell, and here's another one. And if you're to go back and to compare it to the primary tumor, you would know that this is a scattered residual viable tumor cell in the sea of fibrosis and necrosis. And what does this mean? And so the issue here is, of course, what is the significance of non-viable or minimally viable tumor at a margin? And the answer is, there are really no good studies to tell us this. And it would be impossible to design such a study, really, because how would you control for having scattered viable cells? How do we know that even if we have a viable cell, that it isn't or is capable of reproducing, since it has seen, obviously, neoadjuvant radiotherapy? So there are a lot of questions that become very, very difficult to address. So this is one of many issues when it comes to tumor at margins or close to margins that really is in need of more rigorous study and frankly, open conversation. There are a couple of other issues related to that. Some of them relate to enucleation. So you've got a specimen that's been enucleated. What is the margin, if at all? Is there a fibrous pseudo-capsule? Is that enough, or is this a problem? What do we do about well-differentiated liposarcomas that march up to an inked margin, or a dedifferentiated liposarcoma that becomes well-diff, that becomes a mature adipose tissue and then an inked margin? Do I have to do FISH at every one of these margins to confirm whether or not it's a tumor or not? I mean, again, these are all questions that really beg answering. And just by way of a quick example, this is a synovial sarcoma that's seen neoadjuvant radiotherapy, so some response to treatment. And when that mass was resected, according to the operative note, another nodule just sort of popped out. And so this is the nodule that popped out. And what do I do about a margin here? I mean, some of it appears to have a fibrous pseudocapsule, and some of it appears to be tumor right up to the margin. Is this a real margin? Do I need to be worried about it? How do I document it? Here's another case. This is a dedifferentiated liposarcoma that's had a relatively good response to neoadjuvant therapy. And here's an area of well-differentiated liposarcoma next to it. And then this would go up to margin. Do I need to FISH this or do immunohistochemistry here to say that this is indeed a well-differentiated liposarcoma that comes up to margin or not? Again, questions that have yet to be answered. And there, finally, in the few minutes remaining, this last case that I have is an 81-year-old woman who presented with a myxofibrosarcoma, and based on the morphology on imaging was deemed appropriate for wide resection up front without neoadjuvant therapy. So here we have a deep-seated mass, and I suspect many of you are recognizing a structure that Jay alluded to earlier, this tail. And what is the significance of the tail, and how does this impact margins and surgical planning? So to come back to this image that I showed you at the very beginning, where it looks very, very clear, like we should have no problem assessing this margin. Here we have a higher magnification of this tumor. It looks like a high-grade undifferentiated pleomorphic sarcoma, although maybe a bit of myxoid areas interspersed. So perhaps this is a myxofibrosarcoma that's just overgrown the myxoid component. And here's a sample of the tail. What does this mean? I mean, obviously this doesn't look like the primary tumor. Is this reactive? Is this a low-grade myxofibrosarcoma telling us the actual diagnosis of the primary mass? Or is this something else? So, oops. Here's by contrast, this is a section from a patient with so-called massive localized lymphedema. This is a mass that you often will see in patients with morbid obesity, often morphologically mimics a liposarcoma. And you can see bouncing back and forth with the tail that it looks very similar. So is that tail benign? But here's a low-grade myxofibrosarcoma, somewhat on the intermediate grade. We do have atypia, but these can be very, very bland and look ostensibly identical to the other two slides that I showed you. So what does it all mean? Well, the issue here, of course, that I'm trying to make is morphologically distinct areas of peritumoral edema are morphologically ambiguous. Are they benign? Are they malignant? And Jay mentioned work that came out of our group. I'm going to go back a couple of decades to the 70s, where I suspect many of you will recognize his name. It was well known that areas of neovascularization and edema were present in and around these tumors, and occasionally tumor cells were present. So we knew this going on for quite some time. This is the image from the same paper that Jay showed. Here we've got a tumor, here we have a tail. And the pathologist of record, and in fact, the senior author on the paper was Rita Candle, my boss, and I would never say anything negative. But you can see here in one of the images, we have a very bland area, and here we have scattered atypia. And based on morphology and based on immunohistochemistry that would now have been available several decades later now bringing up to the early 2000s, is this really neoplastic or not? And the answer is it's still ambiguous. And so now, coming up another couple of decades, we have a wonderful surgeon that's joined our group, Dr. Kim Soy, who's bright and energetic and inquisitive and doing really, really rigorous things to try to interrogate and answer these really difficult questions. And I have the fortune of being the pathologist of record with some of this work. And here's a project that she's working on where basically we're looking at UPS and mixed fibrous sarcoma. Here are the tumors at the top. Here's the tail at the bottom, again, morphologically ambiguous. And the question is this tail malignant or not? And so to answer this question, Dr. Soy is basically taking these tumors and specifically taking an area of the tumor. So here we see the tumor, the tumor. Here we can take the tail, where oftentimes we'll macro dissect or micro dissect this out for her, and then an area of normal tissue. And specifically, she's looking at tumor that has a genetic signature of malignancy. So there's a point mutation, and they have, through digital droplet PCR developed probes to confirm the presence of tumor within that tail. So here's the tumor within the, here's the digital droplet PCR confirming the presence of the mutation within the tumor. It's absent within the normal tissue, but here it is presence within the tail. So we know, going all the way back to the early studies from the 70s and indeed the 60s, that in fact there are a small number of satellite cells lurking within these tails, which is hugely important. So in summary with this case, the presence of peritumoral tissue may contain cells of unknown significance. They've got atypia, but what does it mean? They may be neoplastic. In some cases, they may be examples of radiation-induced atypia. It may be just atypia induced by lymphedema and some of the reactive changes that we see with that. And we really need much more rigorous, that is rigorous compared to morphology, means of assessing the significance of these cells. So in summary, margin assessment is not black and white. There are many challenges. Much more rigorous study is necessary. And to come back to the point about margin assessment, at the end of the day, really careful communication between the surgeon and the pathologist is really, really paramount in assessing margins and making sure that the results that we're reporting are valid. And I apologize to Dr. Catton. I've cut into his talk by a moment, but thank you.
So thanks, Brendan. You know, I think for all the surgeons, you know, we show up at tumor board or else we get the pathology report in the mail, and first thing we do is we just want to find the line that says margins, and you've shown how much work happens between the end of the resection and everything that happens through pathology, and how difficult it is and how many problems there are in providing us with that really important quantitative but also qualitative assessment that you know, is very, very important for our quality control, but also in trying to predict, you know, what's safe. So you know, most of these cases we've been talking about rely on combined multidisciplinary neoadjuvant management. Charles is going to talk about the last part, which is, I think, for us probably the most important, probably one of the most important parts, is how to integrate radiation therapy into these decisions for patients.
Great, thank you very much for the opportunity to speak to you today and for the kind invite. I'm going to wrap up, and I'm not going to spend a lot of time reiterating what's already been said, but I'd like to try and bring my own perspective into this question of how to integrate margins or the question of margins into management. I have no relevant disclosures. You've already heard that the role of radiotherapy is to improve local control in combination with surgery, and improved local control leads to organ and structure preservation, hopefully, and improved functional outcome. And it may also improve survival in specific situations. And you've also heard that one of the main predictors of local control is margin status, and that includes both the quantity of the margin and the quality of the margin as well. But there are other important factors which need to be taken into consideration, which includes the anatomic location in truncal extremity, that can include the depth, and in any anatomic location, it can include relationship to adjacent critical structures. Tumor grade is important, histology is important, and something that is frequently not emphasized, the nature of the prior treatment or even the prior intervention can be a major factor in determining ultimate local control. So how does this radiation oncologist think about margins? Well, I have to consider the scenario of the patient. Are we dealing with a preoperative scenario or a postoperative scenario? If the patient is postoperative, then a decision has already been made, for better or worse, about the extent of the resection. But on the other hand, the quality and the quantity of the margin is known when the patient is seen. And at that point, my options are to recommend observation, irradiation, or even re-resection, depending on the situation. And this could in turn rotate back to a potentially preoperative scenario. So in making this decision, we need to consider a number of different factors. First of all is the need for radiation, and that's determined by our estimate of the risk of recurrence without radiation using all the factors that I mentioned previously. The second is the feasibility of giving radiation. We may decide it's potentially a good idea, but does the anatomic location permit an adequate dose? With modern techniques, it generally does. You could generally find a way to do it, but not invariably. Thirdly, there is the consequence of giving postoperative radiation. It is going to impact toxicity and function to some degree, and then the question becomes, does this risk justify the added value in local control? Which then leads to the final issue, which is the importance of radiotherapy in a particular situation, and that relates to the feasibility and the safety of using the alternative of a local surgical salvage if observation is selected. Now, when a patient is seen in the pre-op scenario, it's a much more nuanced situation. At that point, I must decide with the surgeon on the relative merits of surgery alone versus adding radiation to the care plan, which can either be done preoperatively, or we could do the surgery and then make the determination postoperatively. So we have no information from the surgical margin to help with this decision, and we need to predict the anticipated surgical margin through a careful review of imaging and a discussion with the surgeon. And the decision for the role and timing of radiation must consider the anatomic location, grade, and histology of the tumor. In other words, the biological factors, the impact of the choice of pre or post-operative radiation on functional outcome, and that also relates to the specific risks of combined therapy. Is it better to give it preoperatively or postoperatively? For extremity tumors, we prefer preoperative radiation, but we'll certainly consider postoperative radiation, particularly in the situation where we think there may be a chance to avoid radiation altogether. Now, as has already been discussed, not all margins are created equal. For extremity truncal tumors, you may have an intact fascial boundary. Their effective salvage surgery may be practical in certain situations. Pre or post-operative radiation is usually feasible. We prefer preoperative radiation for a number of reasons, but certainly post-operative radiation is a perfectly reasonable alternative. and one may reasonably choose observation without radiation at all for superficial or low-grade lesions. As you've heard, in the intra-abdominal retroperitoneal setting, it's a completely different situation. There's generally no fascial boundary. Margins are usually narrow or positive. Sorry, I'm getting... And salvage is usually not effective. And we also know that giving postoperative radiation is substantially more toxic than preoperative radiation and has very low efficacy. So you can argue the merits of using radiation at all, but if you are going to consider it, it really needs to be considered in the preoperative setting. And if you don't, you may be forced to choose observation postoperatively, even if it really wasn't your intention. Head and neck sort of falls between the two extremes. Again, there's generally no fascial boundary. Margins are usually narrow or positive to protect function. Effective salvage surgery is usually not feasible because it is extremely mutilating. But on the other hand, you can usually deliver postoperative radiation to the head and neck. It may not be the optimal approach, but it is certainly a reasonable and viable approach. So I'd just like to finish up now with a bit of data. And this is outcome 5-year local control with respect to surgical margins in a number of from a number of different centers. This is by no means comprehensive. I have chosen these primarily because they're large series and they are fairly recent series, and each one illustrates a specific point. The first one is Ahmad and others from Mass General in Boston. It's a fairly large series. There's 382 patients. It is a highly selected series because all the patients received radiation. So the question they were really asking is, what is the impact of margin status on patients who have been irradiated? And what they demonstrated is that, and in fact, every one of these series demonstrates that a positive margin, and it's usually an inadvertently positive margin, is a bad thing. And in this particular series, it is statistically inferior 5-year local control of 83% with a positive margin versus 90 to 100% with a negative margin between less than 1 millimeter and greater than 5 millimeters. And there was a trend towards improved local control as the margins got wider, but even with very narrow margins, there was excellent local control. At the other extreme, we have this large series from Germany, 643 patients from Herati and others. The important point of this series is that radiotherapy was not a routine thing. And it's not clear from the paper how the decision was made or even whether all the care was given centrally, but only 42% of patients receive radiotherapy. Again, like all the other series, a positive margin was a negative predictor for 5-year local control. But with this series, even the best group of patients, negative margin greater than 5 millimeters, the local control in their best group was worse than in the worst group of all these other series that routinely use radiotherapy. The other center I wanted to present is Birmingham, and Fujiwara has published 2 cohorts of patients, and they separated them out into non-infiltrative tumors, of which there were over 500, or infiltrative, what they called infiltrative tumors, and their definition of infiltrative was undifferentiated pleomorphic sarcoma or myxofibrosarcoma. They used radiotherapy quite routinely, 75 to 79%. As everyone else showed, a inadvertent positive margin was a bad thing. And they also showed that in this group of mostly irradiated patients, the margin status did make a non-significant difference as it went from less than 1 millimeter to greater than 5 millimeters in the non-infiltrative group. Same thing seen in the infiltrative group, but it required larger margins in this group of patients to achieve the same level of local control as they did in the non-infiltrative group. And then finally, there is our own series, which Jay has already discussed. It's got over 2,000 patients in it. We use radiation, apparently, I didn't know this, 67% of the time, but each one of these cases was, radiation was used as part of a multidisciplinary decision, usually done at tumor board. And what we, I think, uniquely brought forward was the context of the margin was as important or even more important than the width of the margin. Like everyone else, we found that an inadvertent positive margin was the worst case scenario. But interestingly, even if that margin was revised to a negative margin, even though there was improved local control, there was still a negative. It was still a negative predictive factor. The patients that did the best, with 96% local control, had negative margins, and it didn't really matter what the width of the margin was. We had very few local failures in this group with negative margins and multidisciplinary consideration of radiotherapy. Your planned positive margin also did very well with radiotherapy with 90% local control. So margin width does have bearing, but equally or even more importantly is the context of that margin. Whether a patient is infiltrative or non-infiltrative probably has some bearing. Certainly we are much more inclined to use radiotherapy for superficial tumors that are infiltrative. And routine consideration of radiotherapy also appears to be a major factor in achieving good local control. So that's all I really wanted to say about that, and I will stop there. Thank you.
Thanks, Charles. So I think that puts everything together really nicely in terms of our general approach. What is a typical approach to extremity deep sarcomas, resection in RT, or neoadjuvant radiation? What about chemotherapy? I mean, I guess before we started, we were talking about this ongoing debate of chemo. I mean, I think in the I could maybe just comment in the extremity, and Carol could talk about the retroperitoneal. I mean, the extremity, you know, our group's kind of view is that there's really no good prospective data showing that neoadjuvant chemo improves survival. And, you know, based on the data we have, there's very little, I'd say, need for neoadjuvant chemo on a regular basis to improve local control. We tend to use chemo up front in very extreme cases of what I guess what Carol mentioned before, like tumors that are unresectable or where resection would cause incredible morbidity, or maybe patients would need an amputation. We often try multimodal therapy then and try and downstage the tumors to see if we can improve the resectability, make an amputation limb salvage, or make limb salvage resecting a nerve or vessel without that. We would probably tend to do that more so in something like synovial sarcoma, where we know at least a third of the 20 to 30% of patients might respond with local improvement. But most sarcomas, at least in the extremity, do not tend to show very significant improvement with chemo. And so we sort of just use that very selectively. The other issue is that obviously a lot of the patients are older and can't tolerate high dose, adriamycin biphosphonate chemotherapy. So our general view is not to provide neoadjuvant chemotherapy for most extremity sarcomas, except in these select instances. And I think in the extremities, so you can talk about RPS.
Sure. So for retroperitoneal sarcoma, yes, I think we restrict ourselves to patients who have borderline resectable or unresectable, however we're defining that, sarcoma. When it's a leiomyosarcoma, we have a lot more hope that there will be some response. It may not be downsizing, but the tumor may respond in terms of vascularity and density. And we use it as a measure of biology as well. Patients who don't respond or develop metastases or progression on chemotherapy, we sort of view that as a confirmation that resection was not a good idea in those patients. For high-grade retroperitoneal liposarcoma, it's more challenging. We do see some responses to adriamycin ifosfamide in those patients, but the tolerance is also an issue, and you have to be very careful. I'll just put in a plug for STRAS-2. So STRAS-2 is randomizing patients to 3 cycles of chemotherapy prior to surgery versus surgery alone for resectable retroperitoneal sarcoma. It's either high-grade liposarcoma or any grade of leiomyosarcoma. The leiomyos are getting adriamycin DTIC, the liposarcomas are getting adriamycin ifosfamide, and it's 3 cycles. So if you see patients who are suitable for this trial, it's actively accruing patients. We just put our first patient on and was randomized to surgery only. So that's pretty exciting, and we would really welcome any participation from members of the Swiss Sarcoma Academy or anywhere else in Europe. Thanks.
Or anywhere.
Anywhere.
Well, thanks so much, Carol. I think we take also the opportunity here to bring in Axel. At the recent ESMO meeting, you made a big statement on chemotherapy, neoadjuvant chemotherapy, pros and cons. You argued with cons. Maybe you want to comment also, let's say, on this topic in this context.
I give a talk for cons, but I'm more in favor. So it's a complex situation. But I totally agree with Carol and Jay. The chemotherapy, induction chemotherapy, has to be delivered or proposed only in case of unresectable or marginally resectable. For retroperitoneal sarcoma, it's another context. We never use except the inclusion of the patient in STRAS-2. It's a very low inclusion in this study because a lot of patients refuse to be randomized between induction chemotherapy followed by surgery versus surgery alone. As you can imagine, it's complex to sell this kind of randomized trial. So it's not a standard in retroperitoneal soft tissue sarcoma. We use only neoadjuvant doxorubicin in LEIO and doxo-EFO in lipo, in the differentiated liposarcoma, only for patients with unresectable disease. Because the vast majority of retroperitoneal are operable. Of course, with maybe an R1 resection, we try to avoid an R2. But even in very huge disease, an R1 resection can be achieved even with removal of critical structure.
Very good.
For member, if the patient is totally operable, we operate upfront. We use more and more induction radiation therapy than induction chemotherapy.
Very good point. Maybe also another question. If you perform a pre-op radiation and your surgery ends up, let's say, positive with an R1 margin positive, do you administer a radiation boost, or do you observe, or what's your approach depending on histology and the critical structures?
So we used to take the view that anyone who had a positive margin after pre-op radiation would get a boost. But we did a paper looking at our whole experience of patients who had positive margins and ended up, was it valuable or not? And there were a number of reasons why people might not get a boost afterwards. A lot of them were wound complications and other complications that just prevented radiation from being given. And when we looked at our whole experience, we found that there was no benefit to giving a boost after pre-op radiation, even if there was a positive margin. I remember Brian O'Sullivan used to always say, even though we did this for a time, at one point he sort of said, it really doesn't make sense. You know, you give this big, massive amount of radiation to this whole wound, and then you guys get a positive margin. You can never tell us exactly where it is. Like, you've opened the leg, you've closed the leg, it's somewhere in there. You don't even know where exactly it is once everything's healing. And then you think that if we give this little extra bit of radiation to this area that we think we know where it is, that's going to somehow kill the cells that it didn't kill before. So after we did that study, we stopped doing it. And then I think MD Anderson and Dana-Farber did similar studies of their data and found similar that there was no obvious benefit. Now, we didn't stratify patients based on that Toronto context classification of what was the sort of context of their positive margin, but in general, we've sort of stopped doing that completely.
I'll just also comment about our experience with brachytherapy in retroperitoneal sarcoma. Just don't do it. That's my advice. We were basically acknowledging that there are close margins in many of our liposarcoma cases, and using afterloading catheters to deliver an extra boost of radiation to the tumor bed. But there are so many feasibility issues, and you end up, just as Jay was saying, sort of selecting the place that you could put the catheters, not necessarily where the risk was the greatest. And then we ended up with a lot of toxicity to retroperitoneal structures such as the ureter, femoral nerve, and the duodenum in particular. So we had very high complication rates and no apparent benefit. So we have completely given up on that idea.
Yeah, and I mean, some centers even, you know, have intraoperative radiation, right? Like, you know, at Sloan Kettering, when we were there, they were doing that a bit, and some other places have that technology. And it's hard to imagine, once you've given a sort of targeted appropriate dose, that if that doesn't work, I don't think there's really any evidence for those. It's very anecdotal, that experience, similarly.
Axel, at your center, do you use intraop radiation brachytherapy for retroperitoneal?
No, we never use here. Too complex.
There was a question from, please.
A rapid question to Jay. You mentioned at the beginning, in some cases, you find some residual cells until 4 centimeters from the capsule of the sarcoma. Is it related to some histological subtypes when you find some histological residual disease? Very.
Yeah, I don't know. It's a small number of cases like that study, but it'd be a really interesting thing to look at again. I wonder if it's not more likely to be something like myxofibrous sarcoma, because in our study that we did, like we did the Toronto margin context classification, the tumors that were in that fourth group, the inadvertent positive margins, right? Like Peter and I operate on a brand new tumor, it's never been violated, and we get a positive margin inadvertently that at the highest, those tended to be UPS and myxofibrous sarcomas, not exclusively, but the majority were. So if I had to venture a guess, I would think that those are the tumors where it's most likely that tumor cells are probably far enough away. And the thing though is that, you know, when we have this paper looking at the outcomes of myxofibrous sarcoma, and our results are actually, surprisingly, the local recurrence rate is very low, often despite having a positive higher margin rate. And I think part of that is just, you know, because we take into account this issue of edema. Like, we've shown that edema is almost like a surrogate for the extent of tumor cells. And for a long time with Charles and the radiation group, we've been covering edema, and that's not conventional, and I don't think in sarcoma radiation oncology. We cover not only the conventional volume, but then the entire volume of that edema. And when it's feasible, we actually even try and resect the areas of edema if it's not going to change the morbidity for the patient. So we go to a big extent of addressing perilesional edema, and I think that is probably one of the things that helps with our recurrence risk, because it's just another surrogate for what's the extent of tumor that you can't visibly see otherwise, histologically or by other means, as Brendan even showed, right? It's really hard to identify single tumor cells anywhere. We're trying to identify it molecularly now, but still it's just a bit of a concept so far.
Yeah, Jay, your
cells are there, they exist, we just don't know where they end.
Yeah, you're probably right. There was in that study, it was most likely myxofibrosarcoma, and they tend to be the ones that disperse the furthest. It's also important to emphasize that that paper was a couple of decades ago, and the diagnostic criteria for all of these things has completely changed. So this is why it's so important with every new study to go back and reevaluate the histology to make sure that the diagnoses are up to date with the WHO.
Any further comments? I really have to and want to congratulate you and the entire Toronto group. Not only what you contributed, of course, over all the years, your patients benefited most, but sharing your knowledge and experience with us here is a great treasure, actually. And you said in the beginning that you did not talk to each other to really fine-tune your presentation, but it was just absolutely spectacular. I think you gave us a really deep insight of your practice, and I think we have data from the French sarcoma group how important the multidisciplinary team approach to sarcoma is, but you showed here actively how you live it, and I think this is just tremendous. I cannot thank you enough for this contribution. Any other comments from you, Axel?
No, it was a real pleasure to listen to the experience of Toronto. We love this team since a long time.
Please continue to contribute this way. We are eager to hear more from your group.
Thanks. Well, thanks for having us in the European mix.
Thanks so much.
Always happy to participate.
If you are all interested on agreeing, I would love to share this information in the forum so that people can discuss there and continue to exchange experience. Having said that, again, many thanks.